53-year-old male complains of fatigue. Physical exam reveals pale conjunctiva and a rapid pulse rate. Lab work reveals low red blood cell count and increased reticulocytes. His med history is significant for lower back pain, treated with an over-the-counter med daily. What GI adverse effect is most closely associated with the drug that would best have prevented the underlying cause of his fatigue? Constipation, diarrhea, gastroesophageal reflux disease, esophagitis, malabsorption of fat-soluble vitamins, or sulfur aftertaste? The correct answer is diarrhea. He likely has a GI erosion with blood loss caused by an NSAID like ibuprofen, so misoprostol would have been preventative. Some folks suggest that there's a direct chemical interaction between NSAIDs and the phospholipid bilayer that plays a role in NSAID-induced gastritis. NSAIDs also uncouple mitochondrial oxidative phosphorylation, and inhibition of cyclooxygenase leads to loss of prostaglandin E2 with subsequent decreases in bicarbon mucus. So IV NSAIDs also pose this risk of erosion, so I think that it's probably not just a chemical interaction. At any rate, NSAID-induced gastritis and ulceration is real. Misoprostol, generic for Cytotec, is a PGE1 analog. It's indicated for NSAID ulcer prophylaxis, and it's going to increase GI bicarbon mucus secretion. When inserted vaginally, it's also used for cervical ripening prior to parturition. It can also be combined with RU-486, mifepristone, as an abortifacient. Side effects? Well, GI, it's not well tolerated. Lots of GI cramping and diarrhea. It's also contraindicated in pregnancy unless, of course, you're inserting it vaginally to prepare the cervix for vaginal delivery. A 65-year-old complains of frequent emesis and heartburn since beginning drugs to treat newly diagnosed Parkinson's disease. Which drug is most likely responsible? Benztropine, entacapone, levodopa-carbidopa, metoclopramide, or selegiline? Dopamine is a potent activator of the vomiting center. So levodopa, a precursor to the formation of dopamine in the CNS, can activate those central dopamine receptors to cause nausea and vomiting. If you look at benztropine, antimuscarinic, more likely anti-nauseant. Metoclopramide is a dopamine D2 blocker, therefore it's not going to be used to treat Parkinson's disease, number one, and number two, it's antiemetic. Selegiline, monoamine oxidase inhibitor, could cause nausea and vomiting, but it's not the most likely agent. Here we're seeing some selected causes of nausea and vomiting. We're not going to talk about the list on the right. We're going to focus a little bit on the list on the left. Most drugs, remember, can cause some dyspepsia and nausea, but not necessarily all causing vomiting. So let's just pay attention to the ones in red and maybe a couple of others, but we'll talk shortly about cannabis hyperemesis syndrome. We've already talked about our incretin mimetics, our GLP agonists. They can cause gastroparesis, which can cause nausea and vomiting. And of course, as we saw in this case, dopamine agonists can activate those dopamine receptors in the vomiting center and other places to lead to nausea and vomiting. A 22-year-old presents with severe pain and intractable vomiting. The only thing that helps is a hot shower. He admits to daily use of ethanol, cigarettes, cannabis, and frequent use of morphine and methamphetamine. Which is the most likely cause? The cannabis, the cigarettes, the ethanol, the methamphetamine, or the morphine? This is a classic cannabis hyperemesis syndrome. Younger man, frequent use of cannabis, particularly of higher THC content. Not quite sure what causes it, but it may be associated with pathologic bathing behavior, prolonged hot baths and showers. It's kind of a patient self-treatment, and it's thought that the TRPV1 receptors are activated and desensitized by heat exposure during the hot bath or shower. It's also postulated that cannabis hyperemesis syndrome, at least in part, is related to upregulation of those TRPV1 receptors. On to the next case. We have an overweight 45-year-old female who complains of severe right flank pain and blood in her urine. She endorses that she's having increasing difficulty with night vision. She's taken an over-the-counter weight loss aid for the past 4 years and admits that she has frequently oily diarrhea because she just can't stop eating fatty food. What is the likely underlying cause of her visual disturbance? And what about the flank pain? Is it due to cycloplegia, due to induction of carbonic anhydrase? Is it due to meiosis, mydriasis, or vitamin A deficiency? What we're looking at here is probably vitamin A deficiency. Remember, vitamin A is really important for vision, particularly nighttime vision. And we're seeing steatorrhea causing loss of A, D, E, and K. Binding of calcium to fats in the GI tract means oxalate is reabsorbed, so oxalate kidney stones may happen too, flank pain, and bloody urine. So she was taking orlistat. So to summarize, drugs that alter motility, secretion, absorption as a side effect. And remember, iron can do either, as can many drugs like NSAIDs. So decreased motility, the eye can't move. I incretin mimetics, C, cholestyramine, ding ding, cholestyramine. And don't forget it may cause high triglycerides and deplete A, D, E, and K also. Aluminum is the A, N for NSAIDs, T for thiazides and diuretics because of dehydration, M for antimuscarinic, O for opiates and octreotide, V for verapamil, S for sympathomimetics and dopaminergics, and S for serotonin 5-HT3 antagonists. On the increase side, sorry for my crude mnemonic, C bags of poop, C for chemotherapy and colchicine, B for beta blockers and dopamine blockers, A for antibiotics, G for alpha-glucosidase inhibitors, or the A for alpha, S for serotoninergics, this time agonists, O for osmotic and other laxatives, including sorbitol, fillers excipients like lactose and gluten, P for prostaglandins like misoprostol, O for opiate antagonists, O for overzealous thyroid replacement, O for orlistat, remember steatorrhea, A, D, E, and K deficiency, oxalate kidney stones, and finally P for proton pump inhibitors.